Care Foundation. Welcome and thanks for joining the webinar today. We are just getting going and going to give people a few more minutes to hop on. So please just hang on the line. All of you are in listen-only mode. So just letting you know that if you have any questions at this point, you can send us a question via the question option on your screen. And we'll begin shortly. Hi, everyone. This is Stephanie Teleke with the California Healthcare Foundation. It is noon, and so we are going to be prompt and get going because we know some of you may have limited time. Thank you so much for joining this webinar on the C-section social media analysis that CHCF funded Monitor 360 to do. We have on the line here as presenters today, Alex Cole and Tricia Mittel, who will be sharing with you some of their findings from this work. We thought it would be helpful to share this with a lot of the partners that we've been working with in the state. So I'm really pleased that so many of you are able to join. Just a few housekeeping things before we get going. As I mentioned earlier, all attendees will be muted for the presentation. So if you want to ask a question, please raise your hand using the raise your hand icon that you should see up in the upper sort of right-ish corner of your screen, or you can also type your question in the question and answer box. We are going to let Alex and Tricia have the floor for about 30 or so minutes to give their presentation, and then we will take questions. If there are any clarifying questions as they're going through that you really want an answer on, we'll be kind of keeping our eye on, I'll be keeping my eye on those and we'll jump in with those, but otherwise we'd like to let them get through their presentation. The webinar will be recorded, just so you know that, and we will be posting the slides and the recording on CHCF's website in about a week. So just to kind of orient you to the work, since many of you are, or all of you are our partners in some way or other, I just kind of wanted to position this work that we funded in the larger context of the projects that we've been funding. So I think many of us know that there are many different levers, if you will, that need to be pulled to make the kind of change happen in California that we hope to see around C-section. And CHCF has one model that we think of it sort of in, there's sort of 6 needed things. There could be many more, but we kind of conceptualize it as 6. You need data and transparency. You need to show providers how to make change, so the quality improvement piece. We need to make changes in how we pay so that that's aligned with outcomes. There are other purchaser requirements that can be brought to bear, as we've just seen from Covered California's activities last week. There's policy changes that need to be made, and lastly, there's patient engagement that needs to happen. So we were really interested in this project. This fits into the patient engagement bucket as we think about things to really understand what's happening in social media around this topic. We learned about Monitor 360's work and engaged them to help us kind of understand the social media space around this topic. So that's kind of the background genesis for this work. So I think without further ado, I'm going to turn it over to Alex and Tricia to take it from here, introduce themselves and Monitor 360, and then launch into the presentation. So Alex and Tricia, take it away.
Great. Thank you, Stephanie, and thank you all so much for joining us. We're really glad you could take a little bit of time out of your day. And Stephanie, I especially want to formally thank you for supporting this work. We really had fun doing it, and you are a wonderful thought partner along the way. So I will dive right in the interest of time, and this is Alex, and let me pull up the agenda here. I'll take you through the methodology and the executive summary, give you a little bit of an overview of what we did. Then I'll turn it over to my colleague Tricia, who's here with me in Washington, and she'll go through a little bit more detail on the findings, the insights, and then some of how some of these different narratives that you're about to see break down, and then I'll take you through some of the recommendations and implications that flow from this work. And this, though we were doing this for California Healthcare Foundation, we very much, as we were doing this work, had an eye towards what are the recommendations that would be relevant to the field of folks, no matter where it is that you come from this issue, that these are different thoughts and ideas that you might be able to use in order to help reduce the C-section rate by communicating with mothers. So before I dive in, let me just give you a little bit of background on us that will kind of set up the approach that we took here and what it was that we were looking for. Monitor 360, we are a firm that does narrative analytics and strategy development. We've been doing it for about 10 years, both for folks in the U.S. government, but also a lot of work with foundations and corporations. And particularly for those in the healthcare industry and for foundations and nonprofits that we work with, very often we're doing two kinds of different sorts of analyses that are driving towards different sorts of outcomes. One is behavior change focused and one is policy advocacy focused. And what we bring to that lens is we analyze the narratives that people are using to talk about a particular topic. The narratives are the deeply held beliefs that people have about something that guide their decision-making on the topic. And whether that's behavior change, whether that's a patient or just a person deciding what kinds of practices or decisions they want to make in their life that will dictate health outcomes at the end of the day, or policy advocacy. What is it that you say to somebody to connect with a given narrative that will get them to support a particular policy? And both of those things in our work are, and in your work, I'm sure, are very relevant. We've done a lot of work for different foundations in both of those areas. For the Gates Foundation on policy reforms related to education. We just wrapped up a project with the Blue Shield Foundation of California that was more behavior change focused, specifically on how do we change the cultural conversation around domestic violence. So that is just a little bit of background on us and what it is that we do. And let me dive right into the specifics of what we did here. So the method that we used and what it was that we were looking for. We were looking for what is it that mothers, or either past mothers or expectant mothers, say about C-section. So the first step of that, we looked into the digital universe, online news media, or primarily blogs, parenting forums, or forums where expectant mothers go to find information. That was the main focus of our analysis. For a piece of it, we also looked at Twitter from mothers and expectant mothers. So we isolated content from that universe of people, specifically what they were articulating about C-sections. And we filtered out some of the tangential topics, some of the noise, basically. We looked at a one-year time frame, basically all of 2015. We started with a sample size of around 300,000 and filtered that down to about 5,000 pieces of content that were really the most narrative rich, where people were really expressing a point of view about C-sections. We then two-step process. First, we cluster all of that content according to similarity. So we have an algorithm that can figure out, okay, everybody over here is saying the same thing about C-sections. The technology isn't very good at figuring out what that is exactly. So we then have humans who go in and put a qualitative layer on that and read a subset of that content and actually distill the narrative. What is the point of view that people are actually taking about this? And then we draft that up into something that other humans can understand. But because it's backed by data, you have we are able to quantify how prevalent is a given narrative in the conversation. Then we're able to play with that data in a couple different ways and look at different narrative associations, who seems to be articulating it, or what context is it coming up in. And we'll give you a little bit more of that later. On this next slide here, you will find a visualization of that data, these messy dots and lines. Let me explain a little bit what you're looking at and what this visual is actually saying. So this is a visualization of those different pieces of content. Each dot is a piece of content produced by a mother that's saying something about C-sections. The colors represent content that is articulating the same narrative, and those links show where there's actual links between this content in the online universe. What this kind of a visual is telling us, you'll see it's very dispersed, which means that this conversation is something that is primarily not driven by external events. In some other conversations, where there's a major event that everybody's commenting on, you'll see a much more focused network that people are commenting about different things. Why this is so diffuse is that people are mostly commenting based on personal experience. And because it's diffuse, that means that there's a lot of different opportunities there. There's a lot of different narratives that, A, we need to be concerned about if they're negative and against our objective, or that there's a lot of openings for us to attach to some of those more positive narratives. So let me very quickly walk you through the different narratives that we found so everybody's clear on the definition, and then in a minute Tricia will go into a little bit more of the numbers behind them. But we saw three kind of basic groupings of narratives, those where people were speaking in support of having a vaginal birth. There was a whole segment of people talking about a bad experience they had with C-sections. And then there was a group of people who were either neutral or articulating a narrative that was pro C-section. And just to break those down a little bit, one fairly prominent narrative in the first category, hoping for a vaginal birth, that's just people passively saying, I would like to have a vaginal birth, and they're not going into a lot of medical reasons why. It's really expressing a hope for that outcome. Reject the heavy baby myth. This is a direct counter to the idea or the myth that if a baby is too heavy, you need to have a C-section, and people very vocally saying that that is incorrect. Keep waiting. This is a general narrative about how when you might run into a challenge, often, there's ways around it. If you're patient, if you look for different solutions, you may be able to find a way to still have a vaginal birth. Seeking a VBAC hospital, we found a very active group of people who were very actively seeking out where they could get a VBAC, and a lot of them expressing some frustration that they couldn't find one. In the bad C-section experience category, just painful and unpleasant people recounting their personal experiences about how it was not a good experience for them, it was painful. Breastfeeding affected, a negative side effect of this. Emotionally cheated, that right afterwards they didn't have the kind of bonding moment that they wanted with their baby. And then finally, in this last category, sometimes it's medically necessary. This is the narrative that's really neutral. People saying, I had one, I had to have one, or sometimes you need to have one for these medical reasons, and some of them, as we know, are completely legitimate. And then only about 6% of folks were saying we're opting for a C-section and expressing that in more sort of this is a choice and you should be able to make it those sorts of terms. So just at a very high level, some of the takeaways that we had, I just went through those different 9 narratives and those 3 different categories that they break down into. But some of the meta trends that we see, first of all, the conversation is very much experience-based. It's people relating their personal stories, and it is often void of data or statistics. That medical information, medical statistics, studies, not very present. Very rarely, if at all, are people citing specific groups or organizations that are providing information. It's much more about them, just mothers sharing their personal experiences with other mothers, or mothers giving advice to other mothers. There are a number of things that we look for that were strikingly absent from the conversation, and our approach is exploratory. So we weren't going in with a predefined list of things that we were looking for. We were going in looking at what is this conversation in totality. Some things that were absent, there was very little discussion of people talking about the C-section rate or whether or not it's too high. There's very little discussion about hospitals and doctors pushing people towards having a C-section for negative reasons, like, for health insurance reasons, or to kind of get people through a hospital chair faster. And then finally, we saw an interesting demographic divide, and Tricia will go into more detail and more nuance here. But the big one that stood out to us, low-income mothers and mothers of color were just as frequently or even more frequently expressing a hope to have a vaginal birth, though we found that Caucasian women and middle-income women, they were also expressing that, and were also much more likely, though, to take active steps to seek information to avoid a C-section. So that, at a very high level, are some of the meta findings. I'm going to turn it over to Tricia, who will go into a little bit more detail, and then we'll wrap back around and talk about some of the implications and recommendations for how is it that you can actually manage this conversation and try to help women make fully informed decisions.
Thank you, Alex. So the next slide here on page 10, this shows the distribution of the impact of the 9 narratives that we surfaced. As Alex mentioned, there's no single narrative that's dominating this conversation, but you'll see the 2 most prominent narratives, one painful and unpleasant, which talks about the negative experiences of a C-section and hoping for a vaginal birth, kind of the more passive desire to have a vaginal birth over a C-section. Those are almost equal percentage in the landscape. In contrast, the one more pro-C-section narrative, which is opting for a C-section, appears to be least prominent in the conversation at about 6%. And then some of the others fall somewhere in between there. If you look at the next page, which is slide 11, this just shows the breakdown of the different categories that Alex mentioned. So you see that almost half of the conversation is captured by these pro-vaginal birth narratives, indicating that it's quite positive. Women really do want to have a vaginal birth over a C-section. Another third of the conversation is more commenting on those negative C-section experiences, the side effects, and the pain. And then about a fifth of the conversation is talking about views towards neutral or pro-C-section views. And again, overall, the conversation is in favor of vaginal birth. If you flip, the next section that I'll go over here is we looked at different actors and topics in the conversation to see which narratives they were associated with, and to then think about how we could use that information for outreach recommendations and communications. So the way that we measure this is we look at the percentage of articles within a specific narrative that are mentioning a particular actor or a topic. This is a bit of a blunt instrument, so we use the numbers mainly to drive our qualitative investigation of what those associations really mean. And if you look on the next slide here, slide 14, so these are the different actors and topics that we were analyzing. So it was doctors, partners, midwives, doulas, hospital choice, and C-section rate. You'll see that doctors are the most frequently mentioned actor, and they're seen as information providers throughout the birth process and very influential on, in the moment, decisions around delivery. Partners are the second most prominent, and this includes spouses and boyfriends, and they are seen as support systems, and they're largely mentioned as providing input on the birthing decisions. Lastly, C-section rates and hospital choice you see are have a much more low presence in the conversation compared to everything else, and we'll get to that a little bit later, but that's just one thing we noticed that was pretty absent. A zoom in here on the presence of doctors in the conversation. They're highly visible, but their narrative associations tend to be mixed. So they have some very positive narrative associations, but also some negative ones. They often are criticized for refusing to provide VBACs, as well as for saying that heavy babies require a C-section, and for convincing women to schedule an early C-section when people don't think that's quite necessary. But on the other hand, they do tend to be praised for offering VBACs as an option for women and for respecting a mother's birth choices and wishes. The recommendation here is to convey that mothers don't have to have a C-section just because the doctors tell them to, because there are many hospitals out there that do support vaginal deliveries, and that can be identified in available resources that are out there. For the next actor that we looked at, which was partners, here they're mainly seen as a source of emotional support rather than real influencers in the decision-making process in terms of how mothers are talking about them. They're very strongly associated with this emotionally cheated narrative, and that's because mothers are talking about how partners have to fill in for them after they undergo a C-section in order to provide that skin-to-skin contact and to care for the baby while they recover from the procedure. Partners also tend to be associated with just being generally supportive of mothers' decisions around their birth plans, specifically when it comes to VBACs. One recommendation we saw here was that since mothers view partners as this source of emotional support, communicating to fathers and partners about the emotional benefits of undergoing a vaginal birth over a C-section could be really helpful, since they're usually the actors that are kind of experiencing the mother's negative experiences around these effects of a C-section. For midwives and doulas, they had a lower overall presence in the conversation as well, not quite as low as hospital choice and C-section rates, but when they were coming up, we found that they tended to be associated with all of the pro-vaginal birth narratives that were in the conversation. They have very positive associations with how a midwife and doula will decrease a woman's chance for needing a C-section. So here there are a lot of opportunities around raising the visibility of midwives and doulas in the conversation by having mothers share their positive experiences of using a midwife or a doula to then avoid needing a C-section. There's also an opportunity to educate and inform mothers about some community-based doula programs that can help provide affordable access to birth resources and coaching for women who are unable to have a midwife or a doula. So when we looked at hospital choice, which was one of the key topics, again, it has a minimal presence in the landscape, and you can see that here with the lower narrative associations that are there. It's most often associated with a mother's search for a VBAC-friendly hospital, and with sentiments that mothers are feeling like they missed out on the birth experience they wanted because their hospital decided to perform a C-section. Here, providing easy access to resources for locating hospitals that perform VBACs is really key, because there's a clear demand signal in the conversation for that information. As well as when talking about the importance of choosing a provider with a lower C-section rate, instead of framing it around hospital choice, frame it around the search for a doctor. Because mothers are discussing their doctor choice much more frequently overall than they're discussing their hospital choice. So that could be a better entry point to try to communicate to mothers that when searching for a doctor, there are resources out there on C-section rates for hospital choice. The last slide in this section, we looked at the prevalence of repeat mothers versus first-time mothers in the conversation. Just to note, this was all based on self-identification, so women saying that they had either had one or more children or that this was their first time going through the delivery process. You can see from the pie chart that repeat mothers are overwhelmingly dominating the conversation compared to first-time mothers. And this is because the nature of the conversation is very experience-driven, which Alex mentioned earlier, usually containing questions from first-time mothers about advice and information from repeat mothers. And then often multiple repeat mothers will be responding to those questions, offering advice. So a big takeaway for us here was to use these repeat mothers as spokespeople because first-time mothers are really trusting their opinions and their experiences. So having them be the communicators could be really effective. The next section, we did a demographic and geographic breakdown of the different narratives. Here, just a note, we use Twitter data because it contains much more geographic and demographic information that we can then use to infer the different breakdowns here. So if you look at slide 21, here we just did a comparison of the narratives on forum posts to the narratives on Twitter. There was a lot of similarity. They shared the top two narratives, which were painful and unpleasant and hoping for a vaginal birth. The key difference that we found was that reject the heavy baby myth, which is the circled narrative there, is much less prominent on Twitter than it is on forum posts. And this suggests that the Twitter conversation is a bit less informed than the forum conversation. And this could be because women aren't comparing information as much on Twitter as they are on forums. So a clear recommendation here is to amplify reject the heavy baby myth narrative on Twitter to raise its presence and provide more information about why that is a myth that's out there. The next slide, 22, looks at the racial and ethnic breakdown of the narrative landscape. And so here you can see that we looked at Caucasians, Hispanics, and African Americans. Just one note, Asians are not included here because we were looking at a national sample size, and the total number was just too low to look at Asians for this. So one of the main insights here is you can see that African American mothers specifically were expressing a desire for a vaginal birth, which you can see in this hoping for a vaginal birth narrative, but were less likely to express narratives that demonstrated more knowledge about when a C-section was necessary, how to avoid one by finding a VBAC-friendly hospital, or what techniques could be used to turn a baby around. This suggests a sense of a lack of control within this group over their plans for delivery. In contrast, you can see that Caucasian mothers are less vocal about that hoping for a vaginal birth narrative compared to African Americans and Hispanics, but were more likely to express this seeking a VBAC hospital narrative and some of the other narratives that are indicating kind of more in-depth knowledge about how to avoid a C-section, suggesting a greater sense of control within that group over their birthing process. The recommendation here is to connect with mothers that have this sense of a lack of control by framing the information in a way to connect with them. So for example, using phrases that make them feel more empowered. For example, you can control your pregnancy. Here's what you need to know in order to avoid an unnecessary C-section. The next slide I'm going to quickly go over, this is the income breakdown. We found a lot of overlap. We looked here at middle income and low income mothers. There was a lot of overlap with the racial and ethnic breakdown. You can see that similar to African Americans and Hispanics, low income mothers tended to share more experiences about a negative C-section experiences and passive hope for a vaginal birth, and were less often expressing narratives that were more proactive about avoiding a C-section. And similar to Caucasians, middle-income mothers were more often expressing narratives that reflected more extensive knowledge. So we would recommend kind of using the same strategy for low-income mothers as for women of color, about framing resources about hospital choice in a way to make vaginal birth a reality and help avoid a painful C-section. And here it's key to use mothers really to communicate the information through stories instead of statistics. It's more likely to connect with them. The last slide here is the California breakdown. So we looked at California versus the national conversation on Twitter. And we found there was a lot of similarity between the California conversation and the national conversation, though Californian mothers were more likely to express narratives that were suggesting that C-sections should be avoided. And we also found that they tended to track more with the narrative associations of higher income women. So for example, more commonly expressing this seeking a VBAC hospital and less frequently expressing hoping for a vaginal birth. And this could be due to the fact that California has a higher average income than the national average. So it would make sense that they would trend more towards those narrative associations. So the recommendation that came out of this that we saw was, since a lot of Californian mothers are expressing this seeking a VBAC hospital narrative, there's a clear demand there. So provide resources on the available VBAC-friendly hospitals and increase that interest by pairing it with real stories from mothers who have gone through successful VBAC procedures. So I'll hand it back to Alex to do the whirlwind of the recommendations.
Great. So I will just give you a quick overview of some of the insights and implications and recommendations that we see coming out of this, some thoughts on how best to engage mothers in this conversation, and some of these we've touched on before, and some of them I'll elaborate on a little bit further, and we'll get through this in about 5 minutes, and then very eager to get to some of your questions. So 4 big things that stood out to us in looking at the totality of this narrative landscape and at this conversation, and some 4 big opportunities. So first is using repeat mothers as spokespeople and using them to help humanize medical statistics. Since this conversation is largely experience-based, just throwing out medical information, which is useful, and there's a group of people who's out there actively seeking it, but that is not getting as much traction in the mother-to-mother dialogue. So if you can weave in a personal story about a mother who is then repeating a medical statistic, that may be a good way to try to get some of that data into the conversation. Or just finding a mother who embodies a message that you are trying to convey about a certain risk or opportunity. Second, we really saw 2 different points at which to influence a mother's decision-making in this process. One is earlier on during the kind of planning phases, and then one is much closer to. And I'll go into more depth the different opportunities we see at those different stages. The third one, that there's an opportunity to debunk myths already in the dialogue, but one very important note there: you want to be very sure that you are trying to counter the myths that are already somewhat prevalent in the dialogue, not those that don't exist or that aren't being articulated frequently. If you repeat a myth, even in negation, you can sometimes prime it. So we went through and identified the 5 most commonly mentioned myths, and I'll show you that list in a second. And those are the ones we'd really recommend focusing kind of myth-buster campaigns on, and less so other myths that you may have heard of. And then finally is empowering those who are passively expressing a desire to avoid a C-section, positioning birth planning and different practices that help to encourage vaginal birth, positioning those as a way to empower that audience of people, as a way to take control of their pregnancies and really create the pregnancy that they want, not one that they just will experience without having much influence over. So those are a couple high-level ones. When we think about how to navigate a narrative landscape, we think of 4 different general strategies, and we'll explain the ones that we think of here, but I thought the framework could just be useful for some of you in both this aspect of your work and perhaps others. But we see 4 general approaches. One is avoiding, That's avoiding a narrative that undermines your objective, and avoiding is obviously you're not going to repeat that narrative, but it's identifying what we call the narrative triggers of the language that touch it off, and you want to identify those and be sure not to use them yourself. Second is to attach. That's finding narratives that are already pretty prominent in the conversation that you might be able to hitch something to that you're trying to interject into the conversation. That's an entry point. Third is reframing. That's if there's a narrative that's out there already that is somewhat supportive of what you do, but perhaps the second half of the sentence, the end of the sentence, if you will, doesn't quite land where you want it to. That's an opportunity to reframe, to re-articulate the narrative so that it's more favorable. And then finally is white space. That's places where a particular narrative that would be helpful doesn't currently exist in the dialogue that you can just insert into the dialogue. This is probably a little too much information to go over right now, but I think y'all from the invite have the full copy of these slides, but this is some of our thoughts on how to manage or leverage all of these different narratives. So perhaps if you want to peruse that later, but I'll hone in on a couple key ones. So going back to those two key moments of decision-making to influence, the first is the early pregnancy planning, and there's clearly some low-hanging fruit of mothers who are very actively seeking information about, how to ensure that they have a vaginal birth or increase the likelihood of it. So that's the lowest hanging fruit audience, and there's some certain things to do there to help that audience. As we mentioned, we saw a really significant population of people looking for VBAC hospitals and really saying they couldn't find information about where that is. So there's a real opportunity to highlight that information more prominently. And I think the other big opportunity here, women are talking a lot about doctor choice, not hospital choice, and as we know, hospitals and the rate of C-section of a hospital is super influential, it's super critical in determining whether or not somebody will have one. A good way to enter that conversation is to say, hey, if you're looking at doctor choice, here's some thoughts on that, and by the way, as you're thinking about which doctor you ought to use, be sure to look into what hospital they're associated with, because you're very likely to interact with that team, and that's going to have a major impact on whether or not you have a vaginal birth or not. And then there's resources down those lines that you can provide to folks. So that's earlier on. Closer to pregnancy, I think one thing is encouraging mothers to ask their providers why a C-section is being recommended, if it is being recommended, so that they're not just simply passively accepting it. The provider is forced to articulate some sort of a reason, and if it sounds like a myth, then if they've heard about some of those myths, it may give some mothers pause to investigate further. And I think the other big opportunity closer to is to highlight some of the consequences of having a C-section, particularly for first-time mothers, highlighting that having a C-section means that you are committing most likely to having C-sections in the future. And that is a particularly important consequence to mention. There may be others that will also get attention, but that was one that certainly stood out to us. So finally, a couple things that were not part of the conversation. As I mentioned, medical statistics largely absent, opportunity to interject those into the conversation by pairing them with real-world stories articulated by mothers. There weren't specific influencers, organizations, or individuals that were being cited, which was interesting to us, or doctor motives, hospital motives, things, the conversations about cost, convenience, malpractice. Those sorts of things don't seem to be getting traction in the dialogue, which would suggest they may not be arguments against it that would be particularly compelling to mothers or that would encourage them to look more deeply. Then finally, we did not actually see an explicit articulation of this too posh to push narrative that I'm sure many of you are familiar with. We did see some people talking about C-sections as something that you should have a choice about and kind of articulated in kind of casual terms, but not somebody who was really articulating this too posh to push narrative. And we suspect that's because you may be ridiculed on the internet if you are being really explicit about something like that. That if you're talking about making a decision kind of for your own convenience versus what's best for your baby. So as I mentioned, really important only to counter the myths that are already out there. I'll just go through this very quickly. The 4 that we saw, this heavy baby myth, one about, you need a C-section if the cord is wrapped around the neck, or you need one if you have preeclampsia or are in breech. Those are the 4 that are really prevalent. Those are the ones that I think are worth spending some time countering. And note of caution, if there's another myth that you're aware of, maybe if it's not really being talked about, it may only want to be countered on a one-on-one conversation from somebody who's expressing it, not broadly. Last slide here. So a couple outreach ideas. One, so many parenting forums or forums for expected mothers, like what to expect. You could explore, if you're a healthcare provider or somebody who's an expert, partnering with one of these websites to have an FAQ section where you could answer questions about C-sections and other birth issues. One, the second recommendation, building a crew of mother ambassadors who could go on and answer these sorts of questions on those forums, and actually intentionally mobilizing a group of mother ambassadors. Many of the websites where people are getting this kind of information have ads, so you could have ads that are drawing attention to resources like C-section rates at hospitals and things like that, where you can integrate some of these messages. Then on Twitter, as Tricia mentioned, there's probably an opportunity on Twitter to counter more myths, particularly the heavy baby myth seems to be not being countered there in particular. And it's also a good medium for passing, videos around. The forums are a little bit more clunky for that, but particularly if this key to this is humanizing health statistics, videos that you could pass through Twitter and Facebook, other forums. That's a particularly useful route. So we will stop there and eager to get your questions.
Thanks so much, Alex and Tricia. That was great. We are now in question time. So if anyone has any questions, you'll see on your display, there's a yellow hand kind of up by where some of the other controls are. There's a red arrow and a green microphone, and then further down you'll see a yellow hand. So you can click on that to raise your hand to ask a question, or you can type a question in the question box, which you can find listed there, sort of under where the phone number is on the right-hand side also, and can type a question in there. So please, I'll give you a couple minutes to either raise your hand or put some questions in there. And I guess in the meantime, while people are teeing up questions, I can ask one, which is, what most surprised you? I know you do a lot of different types of analyses of social media for many different clients, and I guess on this particular topic, was there anything that stood out that was really kind of unique to this topic, or kind of was surprising to you?
Yeah, I think one that was particularly interesting is many conversations are event driven. The Ray Rice affair had a significant impact on the domestic violence conversation. We've done a lot of work on the electronic privacy debate, and you have things like Apple, and you have things like Edward Snowden that will really disrupt it, and then will introduce new narratives. And you have narratives that are kind of taking up a much larger percentage of the dialogue. And that often kind of forces you in an outreach strategy, or if you're, trying to connect with people or introduce something new into a conversation, there's kind of one or two big narratives or a couple big events that are your only openings to deal with. And this conversation being much more diffuse, having a lot more narratives, I think there's just a lot more opportunity to connect with different aspects of what mothers are saying. So in that sense, it may be a little bit more malleable in that there's a lot more openings that you can work with.
Okay, that's helpful. And also, I mean, I guess there's an opportunity if these events are happening, 500,000 times a year in California, but there's not sort of one big newsworthy one. So I guess it's also an opportunity. I don't know if there's ever a creation of an event to help with some of the discussions too. I don't know if there's an opportunity to sort of call attention to something on Twitter and make it sort of an event that people pay attention to. Just the thought I had when.
No, I think that's absolutely right, that there does not seem to be a ton of competition out there for those sorts of things.
Someone has a question. Lauren, can I ask you to read that? Because for some reason my screen, I can't see the full question.
Yep. The question is, what are the best sources for finding providers and facilities who are VBAC friendly?
Do you want to take that one, Stephanie?
Yeah, I think Bruce is also on there too if he raises his hand. But in California, anyway, on our on the calqualitycare.org website, there's information by hospital on the offering of VBAC. So again, it's calqualitycare.org, and that's information that's provided by a chart, the California Hospital Assessment and Reporting Task Force that does public reporting in the state on hospitals. Lauren, are you seeing any more questions?
So it looks like Leslie Cragen has her hand up, so I'm going to unmute her for her to ask her question. Leslie, can you hear us?
Yes. Unfortunately, both my computer, I tried to mute. Hold on. Okay, hopefully this will work. First of all, thank you for the presentation. Are you getting an echo?
Yes.
Leslie, do you want to type your question in if you're getting a lot of feedback? I don't know if we lost Leslie. Lauren, looks like there are a couple other questions while we're waiting for Leslie to come back, but for some reason
yes.
I can't speak.
Another question came through. Can you say anything about how expectant mothers weigh conflicting information between friends, family, and physicians?
Yeah, that's a great question. We did see in the conversation a lot of conflicting views. And I think that's kind of one of the powerful things about forum posts is that, if usually the way we weighted that is if there were a lot of different women expressing one viewpoint that kind of overshadowed the other, then, we gave that a little bit more weight in the conversation. But I think it would also then probably depend on if those women are taking that information and asking their health providers or their doctors, who they do see as kind of good sources of information in sort of in the moment decisions, that they could kind of also be another arbiter on kind of what the take is. But I would guess that the more evocative and the more personal that the stories are that are supporting one viewpoint or the other, probably the more likely that mothers are to relate to that viewpoint.
Yeah, and on that, I mean, one thing that I thought was particularly interesting was how when people were talking about information, when medical information came into this conversation, it was sort of my doctor says, or, I heard doctors say. And there, sort of like 50-50, people were either rejecting what a provider had said or agreeing with it. So there was some real debate over information that was provided by doctors. I think there's a temptation to kind of throw out objective medical facts into a conversation, but often it's the story about the personal experience that is harder to refute than medical fact. If somebody said, my experience was X, you can't really say, oh, you're wrong, right? Because that was that person's experience. But you can get into a debate, whether or not somebody in that debate is half informed, over whether or not something you heard through the grapevine from a doctor is true.
Great. Leslie, I just want to encourage you to type your question in since we were having technical difficulties. Lauren, are you seeing any other questions popping up?
Yes, I'm going to unmute Christine Morton to ask a question. Christine, you should be unmuted. Okay. While we see if she chimes in, we have one that came through. I know data in C-section statistics was absent from the narrative. Do you think women would trust or use this data to inform decisions/views if they knew where to access it?
Good question. I mean, that's absolutely right that we were not seeing much conversation at all about the C-section rates. That could be because the tenor of the conversation was just much more experience-driven around these personal stories. So if those rates were kind of embedded in stories about, for example, a woman who is talking about how, as she was searching for a doctor in a hospital that was more likely to allow a vaginal birth and avoid a C-section, and then there was maybe a link to a C-section rate or a kind of discussion about it that came after that, I think that could be effective. And we have seen people talk about kind of finding a hospital that is more VBAC friendly, and so the rate discussion does come in a bit there, but I think to have it be most effective, it should be tied to a personal story on these kind of, in this forum medium.
Great, so Leslie is gonna, hopefully her audio will work now. Leslie, you should be unmuted. Still not working. Okay, so I'm going to encourage anybody who has questions just to type it in. There seems to be an issue with unmuting folks, so please send your questions our way.
While we're waiting, this is Stephanie Teleke again. I'll ask a question. Could you say a little bit more about the spokespeople and having sort of a person who's maybe introducing some new thoughts into the dialogue, but someone who is knowledgeable, and sort of how you go about finding such a person and using them effectively?
Yeah, great question. And, I think finding a spokesperson, it really does, it's worth getting that right. So here, for instance, as we saw, just having a doctor is not necessarily somebody who is instantly going to have credibility. People really seem to latch on to the mothers relating other experience. So I think mothers who have had multiple births are probably going to be viewed as particularly credible messengers in this space, because again, it's hard to deny somebody's personal experience. But I think that it's not, we don't want medical information in this conversation. The power is in pairing it with a mother who people say, oh, okay, this person has had 3 kids. They must know what they're talking about. Oh, and now to back up their personal experience that they had, positive or negative, they're citing this credible source. I think that's the way that you combine credibility, that you really make it credible. And by having a spokesperson who is a mother, you also make it emotional. That's the other reason why those things are, the personal story gets traction. If I say 1 in 5 people do X, I mean, pretty quickly people will fall asleep versus, you know, my personal experience was this. It's just much, much more emotional and much, much more resonant. I mean, and you go to, you know, how do you recruit people? I mean, you know, just mothers off the street are probably not going to be excited and motivated to go on a forum, but, you know, you're also talking about something that, you know, dozens and dozens of millions of people in America have experience with. So you could have a doctor who is a mother who you recruit to be, you know, a spokesperson. They might have added credibility, or they may not even have to mention that their medical credentials, but they'd be somebody who would be giving, you know, reliable information.
Okay, that's helpful. I see a question here from Neil Kohatsu. How did you get income and race ethnicity data from social media?
Excellent question. So we use a method that we get there by inference. So I'll try not to go too much into detail here, but there is an algorithm that can identify certain characteristics of people on Twitter, who they like, who they, you know, who they're following, who they're not following, that correlate to that person's race or to that person's income. And these are kind of well-trodden formulas that have been tested and retested again and again, so that you can infer to, you know, the 95-degree confidence level, for those of you in the, you know, statistical world, that a certain person that you're looking at must be from a certain group. And the sample size is large enough that all told, we feel pretty good about the accuracy. But it's based on who they're following and who they like, and how that tracks in general and trend terms to either race or income.
Thanks. We have another question. What can we as employers do to bridge the sensitive topic of advising new parents on the myths? Employers obviously being the purchasers of healthcare, who often have access directly to their employees or via an insurance company to the members.
Oh, that's a really interesting question. So just to make sure I'm understanding correctly, so employers kind of within, you know, companies or organizations, not necessarily health related, that are advising their employees in regards to their insurance policies and choices. Is that correct?
Yeah, well, some employers self-insure, so they might be actually, you know, providing the care more directly, or they may contract with an insurer. But either way, employers, you know, if you work for Google or you work for Walmart or whatever, they have direct access to their employees and can be, you know, they send them messaging around health often, and increasingly their wellness programs and through your employment. So it's kind of thinking about the role of employers in being able to be messengers on some of these topics. Is that, you know, what can they do that would be effective based on what you learned?
Great. Yeah, I think that's a great opportunity space for more messaging and to reach a broader group of people. I think for that, relying in part on kind of what myths are already in the conversation, so which ones are more likely to be heard and discussed, which we call out, you know, cord wrapped around the neck, preeclampsia, heavy baby myth, getting out in front and debunking these myths with women. But in that type of medium, also perhaps having some people share some personal stories, but that's probably a good venue for also distributing more kind of medical statistics and information. And if there are kind of other myths that are coming up in that forum, women might be more receptive to, hearing about a myth that is less likely, though I would say focusing on the ones that are kind of more prominent in the conversation would probably be best, but I think that would be a great opportunity to engage mothers and educate and inform. Alex, anything to add on that?
Yeah, and I also think if you're an employer and you're kind of sending out general information to a broad group of people, you might want to sort of upframe the entry point a little bit and say, are you in your pregnancy planning? Which might feel more relevant, like, we're an employer and we have a generous, maternity and paternity leave, and here's what that is. And by the way, if you're in pregnancy planning, here's like 5 things to know. And the C-section bit, maybe just part of that. I'm actually just kind of envisioning being an employee for a second. And if I, got an email one day that said, C-section debate, here's, what to think about it. It's such a kind of specific topic that it could feel a little bit like from left field, but if you put it in a broader context and it was strategically one of 5 items on a list, that might just kind of get broader feel and be better received by your employees.
Great, good thought. We do have Leslie Cragen's comment now, so I'll read that. Thanks, Leslie, for submitting that. Midwives care for women with previous C-sections or cesareans and often have higher success rates for women having labor after cesarean. Lauren, can you see the rest of this comment?
Yeah, so it actually starts, as a midwife, I would like the language in the recommendations to reflect that the choice of provider should not be limited to doctor, but be expanded to include midwives. And then she talks about midwives care for women with previous cesareans and often have higher success rates for women having labor after cesarean. She did appreciate that in the webinar you used the term providers, and while choice of provider is important, there may be providers who are supportive of VBAC, but the local hospital is not offering that option. So as you pointed out in the last slide, both choice of hospital and choice of providers should be part of the messaging in communities where there is a choice that is.
Yeah, just a quick reaction. Oh, go ahead.
Yeah, go ahead.
I was going to say, completely agree. I think there wasn't as much discussion of midwives and doulas in the forum conversation that we were looking at, but there's definitely an opportunity to raise the visibility of them as alternative providers to physicians or others. So absolutely agree there.
Lauren, are you seeing any other hands or questions?
I see one more question came through. As you note in point 1, personal stories are very powerful. We recognize there is a whole field of communications that studies how stories, including journalism, are made more impactful. Do you have any brief comments on how to share stories in more effective ways?
Great question, because there are interesting ways to tell stories and there are boring ways to tell stories. And you're absolutely right. There are entire canons of how to tell a story effectively. One resource I will mention for y'all, there is a whole storytelling website. It's called Hatch. I think it's called, it may be Hatch with some modifier, but I think it's Hatch, or Hatch Story, something like that. If you type Hatch Story into Google, it'll come up. And it goes through a whole litany of different techniques that you can use to create a compelling story. I think there's actually there's so many of them. I probably couldn't do it. I couldn't do it justice in the short time that we have together. I mean, in a nutshell, there's two things. One, you have to make it emotional. That's what gets people to read something. And two, you have to make it strategic. Sometimes people are really good at making something emotional and getting people to read a story, but if you don't have a story that's actually highlighting the facts that you want or doing it in the right way, your story may not have accomplished anything. So you got to be strategic about it, and then you got to tell it emotively. It's called hatchforgood.org, Tell Stories with Purpose. It's all about how you tell stories in order to drive an objective, whether it's a policy objective or a behavior change objective like this.
Thanks, that's a great lead. Lauren, any last questions?
It looks like Lance Lang just raised his hand, so let's see if the audio works here. Lance, you should be unmuted.
Hi, this is Lance. Am I on?
Yes, we can hear you.
Great. Great conversation, and I just wanted to tag on to the conversation about midwives and doulas to say that this communication strategy really does need to be tied to delivery system issues. The ability to seek hospitals that provide VBAC, for instance, is also tied to availability of midwives and doulas, and I would add family docs. That there aren't many around the state of California, but there are some who still deliver babies, and they have similar outcomes to midwives. But also, I think obstetricians who are laborious, who support the whole thing by being there to back up and provide the courage to midwives and family docs who are taking on the responsibility. Things do go wrong, and having a sympathetic obstetrician available 24/7 really makes a difference. But combining that with this communication strategy really makes for, I think, a pretty complete program.
Good comment. Thanks, Lance. Any comments back from our speakers?
I was just going to say there are communication things and then there are things. I mean, some of this is, yes, absolutely creating the programs and the resources that will help to address this problem. And that's a critical element of the equation. And then the communications piece of it is to help drive people towards those resources. And you've got to have both of them.
What about the issue of having, some of those resources I think may not be created if, I think one of the mechanisms to have those be created is to have women ask for them. And so there's an element here of sort of education to ask. I don't know how that feeds in. That's, again, maybe the storytelling from women who've done these other things that are maybe less used, like using midwives or using doulas and having those stories come in. But any thoughts there about trying to harness the power of the women's voice to actually have some of these system changes occur?
Yeah, that's a good thought. And I mean, midwives and doulas is probably the biggest opportunity there, where mostly, since we saw that whenever they did come up in conversation, they were seen very positively. So getting more stories out there to create more of a demand signal for those resources. I think most women probably don't know that that's an option, or if it is an option, that it's an affordable option that they can take advantage of. So kind of spreading the word to in turn create that demand makes a lot of sense.
I'm mindful we're getting to be 10 after the hour, and I know some of you are likely needing to drop off. Any last questions, any last hands raised, or Lauren, are you seeing any other comments?
I do not.
Any last questions from anyone out there? If not, then I just want to thank our presenters for sharing the information and doing the analysis, and hope that all the partners who joined on the phone, there were about 40 of you, found it interesting and useful. We certainly at CHCF wanted to share our learnings, and like we said, the slides and the recording from this webinar will be made available on our website sometime in the next week. So feel free to direct and spread to other colleagues if you think others will find it useful as well. We're happy to share. So thanks again, everyone, for taking the time to join.